Bismillah ar-Rahman ar-Rahim. This lecture is intended for the fourth year medical student University of Bahrain and has been prepared by the Department of Surgery and is going to be presented by Dr. Amin Al Awad. This lecture is about acute surgical infection. Acute surgical infection has been been known long time ago, and the complication of as one of the complications of surgery and trauma. It has been documented for more than 4,000, 5,000 years, and the Egyptians, they have had some concepts about infection, and they were able to prevent putrefaction using their skills in mummification, and there came after that the Assyrians, but they have less well documented data, and independently had been documented by the Greeks. In the Hippocratic teaching, they describe the use of antimicrobial in form of wine and vinegar to irrigate the infected wound or wound. And in the 19th century, there were some sort of understudying of this condition. And then came the Koch's postulates. Then came Louis Pasteur, who described his germ theories. In the 20th century, they were able to discover the sulfonamide as an antibiotic, and it has been named as the bullet, the magic bullet. And then it came Alexander Fleming, who described penicillin in the use of infection. The learning objective is to understand the characteristic of the common surgical pathogens, factors that determine whether a wound will become infected, the classification of sources of infection and their severity, the clinical presentation of the surgical infection, and also to learn the Koch's postulate, to appreciate the importance of aseptic and antiseptic techniques, and to be aware of the causes of the diffuse resistance to infection, and also to know the definition of infection and what basic precautions to take to avoid surgical relevant hospital-acquired infections. Acute surgical infections, they can be divided into non-specific acute infection and specific acute infection. The non-specific acute infections, they are in form of post-operative wound infections, cellulitis, erythritals, and boil, carbuncles, hydritis, suppurativa, and acute abscess, acute lymphangitis and lymphadenitis, bacteremia and septicemia. All of them, they are non-specific types of infection. The specific acute infections, they are represented by the tetanus, gas gangrene, and necrotizing fasciitis. Post-operative wound infection as one of which is not a specific type of infection, but they are caused by the presence of contaminated microbes, which are derived from an endogenous or an exogenous sources. The endogenous sources, they present in or on the host. Example, the superficial surgical site infection following contamination of the wound from a perforated appendix, or exogenously they are acquired from a source outside the body, such as the operating theater, inadequate air filtration, poor antisepsis of the ward, or poor hand washing, and the cause of the hospital acquired infection, they are contributing to the development of the post-operative wound infection. The predisposing factors, they are general predisposing factors, poor general conditions, drugs that cause immune suppression or systemic diseases, or local factors such as poor local blood supply, poor surgical techniques, The nature of the operation itself can add to the development of the infection. Defect in sterilization techniques in the operating theater or poor surgical techniques. All these can contribute to the presence and occurrence of the one-side infections. Risk factors for the development of an infection, they are surgical factors or patient-specific factors, which may be local or systemic conditions. The factors influencing surgical site infections, they are mainly patient risk factors, local factors or systemic factors. In the local factors, wound hematoma, high bacterial load, foreign body, wound hematoma, obesity, all these lead to development of surgical site infections. The systemic causes include advanced age, shock patients, diabetic, malnutrition, alcoholism, steroids, chemotherapy, and immunocompromised patients. Factors influencing also systemic surgical site infections are the use of antibiotics as are prophylactically or therapeutically used. The type of the procedure again, degree of contamination, duration of the operation, urgency of the operation, skin preparations before doing an incision also can contribute. Operating room environment, how the theater is being designed and has been sterilized well enough to prevent such form of infections. The use of antibiotics prophylaxis also contribute to decrease the degree of developing surgical site infections. The types of the surgical ones, they are divided, surgical ones, into three categories: either clean or clean contaminated or contaminated ones. The clean ones, they have the risk of 1 to 2% of developing an infection, and the clean contaminated incisions, they have the risk of 2 to 5%, whereas the contaminated incisions, they are associated with 5 to 30% of developing wound infection. In the clean types, which is non-traumatic elective surgery, where the GIT tract, respiratory tract, and urinary tract are not entered, the infection rate is 2%. Example of this is mastectomy, vascular surgery, hernias, thyroidectomy, and other forms of surgeries in which there is no opening of the GI or the genitourinary tract or the respiratory tract. In the clean type of clean contaminated types, the infection rate is less or equal to 10%. In this type, they got like gastrectomies and hysterectomies. In the contaminated type, it's around 20%, and rupture viscous or emergent bowel resects and so on. These are contributing to increase the degree of developing infection. The dirty wounds, such as intestinal fistulas, resections, and so on, they have the incidence of 28 to 70% chance of developing infection. The classification of incisional surgical sites infection. These infections in surgery, they occur in less than 30 days of the procedure, and in superficial types, which involve only the skin or subcutaneous tissue around the incision, you may develop an infection in below 30 days from the operation. And in the deep type of incisions, again, 30 days is the main factor for saying that the patient has surgical site infection or not, or 1 year if in case of an implant, and are related to the procedure also and involve deep soft tissues such as the fascia and the muscles, or it may be in an organ or space as well. There are so many classifications and grading systems. One of them is Southampton's wound grading system, which grade them from 0 to 5, presented by 0, 1A, C, and so on. In 0 there is normal wound healing, but when a major complication occurs, it may be up to 5 deep or severe wound infection with or without tissue breakdown, hematoma, or a hematoma requiring an aspiration. The causative organism of infections ranging from Staphylococci, E. coli, Proteus, Klebsiella, Pseudomonas, or Bacteroides, and Clostridia. Staphylococcus are gram-positive organisms. They include Staphylococcus aureus and Staphylococcus albus and Staphylococcus. These types of microbes, they are more important pathogens which are found in up to 15% of population nasopharynx, and some strains of these Staphylococci are resistant to common antibiotics, especially the methicillin resistant Staphylococci, Staphylococcus aureus, MRSA, and also are difficult to treat. MRSA can be found in the nose of an asymptomatic carrier. Staphylococcus aureus is the most important one of these pathogens. Another organism is Streptococcus, are gram-positive. Most important in the type of them is the beta hemolytic Streptococcus, beta type, group A, which resides in the pharynx of 5 to 10% of the population, and also it's called Streptococcus pyogenes. E. coli, Proteus, Klebsiella, Pseudomonas, Bacteroides, Clostridia, all of them are known to cause diseases and infection. Clostridia are gram-positive obligate anaerobes which produce resistant spores. And Clostridium perfringens is the cause of gas gangrene, and Clostridia tetani cause tetanus. Clostridia difficile is the cause of Pseudomonas colitis. Pseudomonas, on the other hand, they are opportunistic pathogens. They are gram-negative aerobes, occur on the skin surface. They colonize ventilators, IV catheters, urinary catheters, and so on. And they are characterized by greenish pus, which is difficult to eradicate. They may cause lethal infection of surgical patients, and so on. Might also complicate pain, so on. May develop patients later on may develop septicemia. Treatments of Pseudomonas is antibiotic release, aminoglycosides, cefazolin. They can be effective in some patients. Pathogenicity of the bacteria, how bacteria exert their effects. They exert their effects through their exotoxins or endotoxins, or by resisting the host immunity, phagocytosis, by having protective capsules, example strep pneumonia and Klebsiella. The exotoxins, they are specific soluble proteins, and they give their effects, cytotoxic effects, remotely. Example of that are Clostridia tetani and strep pyogenes. Endotoxins, they are part of the gram-negative wall liposaccharides. Example, the E. coli. Koch's postulates provide whether a given organism is the cause of a given disease. For that to occur, it must be found in every case. It should be possible to isolate it from the host and grow it in a culture. It should reproduce the disease when injected into another healthy host, and it should be recovered from an experimentally infected host. Predisposing factors for infection: surgical techniques, contamination, complicated wounds, compromised patients, operative complication, or adverse effects of drugs. In surgical techniques, what happens? Bad skin preparations, break of sterilization, inappropriate use of diathermy, that by burning massive tissues, causing necrosis of these tissues and devitalized structures may become a focus for an infection. Inappropriate surgery, inappropriate suture materials that used for suturing the wounds. Complicated wounds are another factor that contributes to the development of infection. If there is an extensive tissue damage, presence of hematoma or aceroma, again, the presence of foreign body in a wound can contribute to the development of an infection, and the presence of the devitalized tissues forming a good media for culture for the organism to grow. The operative complications: prolonged operation, hypotension during the operation, hypoxia or hypothermia, multiple blood transfusions. All these can contribute to the development of the surgical site infection later on. Patient factors: if they are elderly patients, are more prone to infection than younger. If patients have chronic illness, malnourished patients, obese patients, or patients who are carrier of staphylococcus, they are more prone to infection. The drugs contribute to development of infection. These are the immunosuppression therapies and cytotoxic drugs, corticosteroids, and radiotherapies, because they lower down the patient's immune system. In pathologically, the acute inflammatory stage with local vasodilation and infiltration by polymorph nuclear leukocytes. This is early on occur, and this is followed by the suppuration with virulent discharge. The interval between developing the growth of the bacteria and the inoculation of the bacteria is about 4 hours interval, and for the bacteria to establish itself, it needs this time. And if we can interfere before the development and the growth of the real infection, this is called the decisive period, where we can take hold for preventing an effective effect of the bacteria to occur. And it is therefore logical that prophylactic antibiotics should be given to cover this period, and that they could be decisive in preventing an infection from developing before bacterial growth takes a hold. What are the major and minor surgical site infections? A major surgical site infection is defined as a wound with significant quantity of pus, delayed return to home, causing a patient not to be discharged earlier, and patients are systemically ill. A minor wound infection may discharge pus or infected serous fluid, but are not associated with excessive discomfort, no systemic signs, or delay in return to home. This picture can show a minor wound infection that settled spontaneously without antibiotics. Here again, this is a major wound infection and delayed healing presenting as a fecal fistula in a patient with chronic disease on steroid treatments. On the other part, we can notice that there is colostomy. Delayed healing also related to infection in patients on high dose of steroids. Clinical picture. Wound infection usually appear between the 5th and 10th days post-operatively, and the patient may complain of pain, fever, and you can find other signs of inflammation, redness around the affected area. There is color and heat, and there is dolor, also pain, or there is a swelling and loss of function, and these are the cardinal signs of inflammation they can develop, and giving a picture of inflammatory process. How can we differentiate that the cause is an infection or other causes of post-operative fever? If a patient presented with fever, there are so many other causes of fever. Example, chest infection, deep vein thrombosis, urinary tract infection, and other causes of wound swelling. Maybe the cause of the swelling, not only an inflammation, maybe develop hematoma at the site of the infection, but still at the site of the incision, but still it is not an infected one. What prophylaxis why we do prophylaxis? To improve the defense mechanism, control the predisposing factors. We can give prophylactic antibiotics to prevent that. In bowel surgery, mechanical and chemical preparations are a good prophylaxis for preventing and decreasing the amounts of the bacteria from the bowel, decrease the amounts, and meticulous surgery so as to prevent any collection of blood to develop hematoma or acyroma, or to let the germs or bacteria to be inoculated inside the one side. Operate in complete aseptic area, and if septic area and heavily contaminated wounds are present at the time of operation, then wounds should be left open so as to not to cover the infected wound, and then later on the patient will develop an infection, which is very difficult to eradicate. But we leave the wounds open, and then later on as secondary suturing will be done. What are advances in control of infection in surgery? The use of aseptic operating theater techniques had improved the condition. The use of antiseptics in preparing patients on theater. Antibiotics have reduced post-operative infection rate after elective and emergency surgery. Delayed primary or secondary closure remains useful in heavily contaminated wounds. Again, how can we treat patients with on-site infection? First, we have to do surgical drainage of pus, and to do a good debridement, to take wound swab for culture and sensitivity, because we want to know the type of the microbe that affecting the wound, and to give the appropriate antibiotics for either gram-positive or gram-negative or both of them. Then to have to search for and to look for hospital-acquired infections so as to cut off the chain of infection and to prevent the development of these conditions later on. To increase your knowledge, here is a list of other references that can benefit you during studying your lecture. And the second part, which is going to be discussed in a different lecture, will be about specific and non-specific types in more wide spectrum of talk frankly with you.